want to thank you for joining me. I'm Dr. Jeff Donovan. You're about to listen to the question and answer session from the patient webinar that we had on June 29th, 2022. We hold webinars throughout the year for patients, and it gives patients the opportunity to ask some questions. This was an open webinar for all topics in hair loss, and we had 11 questions sent in before the webinar and 13 or 14 during the webinar. These are just incredible questions ranging from JAK inhibitors and alopecia areata to premature ovarian failure to biopsy results to topical ruxolitinib for scarring alopecia, low-dose naltrexone and N-acetylcysteine for scarring alopecia. Just a wonderful array of questions, and I'm very grateful to all the participants to pose these questions to me. I hope these answers and the discussion that follows is helpful to you. We will post the questions in the show notes with timestamps so that if there's a particular question you're interested in, you can immediately get to it. I'll look forward to seeing you again the next time we do a webinar. We have webinars throughout the year for patients, and they're readily seen on the website, donovanmedical.com/webinars. Our next webinar is in September, and we hold these several times throughout the year. And so stay tuned, and I'll look forward to seeing you again the next time we meet. Thanks so much. Bye. And I just would like to say that these questions and answers are really for educational purposes. And I think it's really important for anyone with hair loss that whoever is overseeing care listens to the story, examines the scalp, and then determines the best course of action with those two pieces of the puzzle. And so the answers that I'm providing today are, to the best of my ability based on the information provided, but sometimes there are pieces of the puzzle that are left out that are really relevant and could change the answer to the question. So let's take a look at question 1. If the Pfizer vaccine has been known to affect women's hormones and menstruation, and shedding follows in the months after, and it's still not corrected 13 or 14 months down the road, and all the blood work repeatedly comes back normal, then how can one correct their trigger? So many people, including myself, seem to be suffering from chronic telogen effluvium, or CTE, or chronic hair shedding after the Pfizer vaccine, and we're unable to stop the shedding after years of trying. After a year of trying. We're only 2 years into the pandemic. A year of trying. So thank you so much for this question. We do know that some vaccines can induce shedding in some patients. For most patients, it's a short-term shedding, and shedding corrects itself in 2 to 4 months, sometimes 6, but usually 2 to 4 months. And for most patients, it's mild, but it can be significant. And so when I listen to this question and I read this question, I'm hearing an individual that's still shedding. It's been a year after the vaccine, and the shedding is still going on. And so the question that comes to my mind immediately is, what is the diagnosis? There are many conditions that look like shedding, and it seems that we should call it telogen effluvium, but that's not the right answer. Androgenetic hair loss causes shedding. Alopecia areata causes shedding. Lichen planopilaris scarring alopecia causes shedding. Other scarring alopecias cause shedding. And so the immediate thing that comes to mind in this question of a patient who's still shedding after a vaccine is, what's the real diagnosis? Is the real diagnosis chronic telogen effluvium like the patient says, CTE? And that's what the patient wishes to believe here, and it might be. But we really need to finalize the diagnosis because it may not be chronic telogen effluvium. So what is the diagnosis? In this particular patient, is the shedding related to the vaccine truly, or is it a coincidence? Now, of course, it seems that it's related to the vaccine, and so I believe that's where the question is looking. But we have to keep an open mind. And it's really important when we evaluate hair loss that we don't let any bias come in our mind. We need to approach each patient as a newbie, with a fresh mind. That is so important. And so if you immediately jump to the conclusion, I hear the patient had a vaccine and he or she is shedding, then you're going to pigeonhole yourself into making wrong diagnoses. And it's common, it's easy to do. Listen, doc, last month I went to the Caribbean and I came back and I'm shedding. Do you think the sunny weather in the Caribbean caused my shedding? Seems likely. What you don't know is that 2 months before that, the patient tried a new cholesterol medication or a new antidepressant, and 1 month before that was sick as anything in the emergency room with high fever. So no, it wasn't the trip to Caribbean that caused the shedding, it's some other things. And so we have to really approach each case with an open mind. Vaccines can cause shedding, absolutely. We know vaccines can increase the risk of alopecia areata. We know vaccines can increase the risk of scarring alopecia. These are rare phenomena. And so that's really important to keep in mind. These are rare. Vaccines may increase the risk of chronic shedding. Or is it something else? And so this is really a wonderful question. I think what's needed here is a diagnosis. We need to solidify 100% the diagnosis. Write it on the paper. What is the diagnosis? Commit to the diagnosis. And if anyone's not sure of the diagnosis, then we need a biopsy, or we need proper trichoscopy examinations where we use these magnifying devices, or we need someone to commit to the diagnosis. What's the diagnosis? Maybe it's a scarring alopecia in evolution, and the scarring alopecia has been grumbling along for 5 years, and the vaccine kind of made it worse. But the scarring alopecia started in 2014 or 16. And so if there's any doubt, we need a biopsy. So the diagnosis is really key here. And certainly if it is chronic shedding from a vaccine, which isn't impossible, then some of the most effective treatments are treatments that cheer on hairs, like low-level laser, like oral minoxidil, topical minoxidil. Those are the top 3. Other things like platelet-rich plasma can be tried, but certainly those are the most effective here. In anyone with chronic shedding, we need the blood tests, and the patient in this question has said, all my blood work is normal, but we need thyroid tests, we need iron tests, we need vitamin D tests, and then we need to listen to the story to figure out if any of those envelopes on the table need to be opened. Is there a chronic infection here? Is there an endocrine disorder? Is there excessive fatigue? Is there excessive thirst? Is there some other thing in the story that leads us to believe that, hey, maybe there's something else going on here? Thank you for that question. Question number 2, what treatments can be used for androgenetic alopecia, female pattern hair loss, if planning a pregnancy? So this is a really common question that I'm asked. And certainly it's very common that we have patients that are planning to become pregnant at some point, and they want to know what treatments are safe and what treatments aren't safe. The reality is that there are few treatments that have really been studied well. And so my feeling is that I'm okay with a patient using a treatment in pregnancy if there's good studies showing that it's safe for the mother, there's good studies showing it's safe for the baby, for the fetus, and there's good studies showing it helps hair loss, all 3 of those. And so if you bring me a treatment and you say, what do you think of this treatment? Well, I don't think there's really any studies showing this is safe for the baby. So right away, we can't use it. But maybe it suggests that it's probably okay for the baby, and it seems safe for the mother, but there's never been a study showing this really does anything for hair loss. Then I wouldn't recommend it. And so there's a lot of treatments out there where it seems pretty safe. How bad can it be? You know, there's certain types of things you inject and things you poke the scalp with and things you do. And it sounds pretty reasonable, but you can't show me a study that shows it's safe for the baby. And that's where we stop. And maybe you can't even show me a study that it really helps hair loss with any convincing evidence. And so that really limits us. And so I'm pretty cautious about the types of treatments I recommend to patients during pregnancy. I think low-level laser is safe based on all the studies that we know so far. But we're pretty limited in my view. And I'm not a great fan of patients during pregnancy having other treatments. We certainly know minoxidil cannot be used. We know that anti-androgens cannot be used, spironolactone, finasteride. Those cause harm. Some practitioners will say other treatments are okay, including platelet-rich plasma, etc. The reality is that there is no good study showing that platelet-rich plasma injected into the scalp of a mother who is pregnant is completely safe for the baby. It certainly seems that it should be safe, but you can't find a study. And so because you can't find that study, these are the 3 criteria that I use. And I feel pretty comfortable using those criteria. And so low-level laser is one of the options which is safe. But before we leave this question, I do want to point out that the best treatment for androgenetic hair loss in women is pregnancy. And so often the hair improves during pregnancy. And so the hormonal changes in pregnancy help the hair a great deal. And so I'm not feeling that unless we do something for these 9 months, the hair loss is going to accelerate. I need to recommend something. I'm not comfortable. The hormonal changes in pregnancy are fantastic for helping support androgenetic hair loss, either stabilizing it or improving it. And many women have a thickening up of the hair during pregnancy. Question 3. My question today is regarding frontal fibrosing alopecia. This is a scarring alopecia that affects the frontal scalp, often in women, but in men too. What's the best treatment? Seems to be all over the place. I was told Elidil cream, which is an anti-inflammatory cream, spironolactone. Some are told to take Zyrtec, which is an antihistamine, known by cetirizine. Some say finasteride, some say Plaquenil, some say Accutane. Can you help me identify the best method? And so it is pretty frustrating to navigate through the treatment strategies for these conditions. When I think of any hair loss condition, no matter what it is, I think of first line, second line, and third line treatments. First line treatments are treatments that we kind of reach for first. When we think of safety and affordability and effectiveness and how easy it is to do, when we combine all those 4 factors, we put the first line treatments first. Those are the ones we want to reach for first. Second line treatments are the ones we go to next if the first line treatments don't seem to be working. And then the third line treatments are the treatments we go to next after that. And sometimes we're successful. We start out with a first line treatment, 1 or 2 of them or 3 of them, and we're successful. The hair improves, hair loss stops, and we never use second line and third line treatments. But every treatment that exists has to find a home in the first line, second line, or third line box. And so for frontal fibrosing alopecia, this is where I place the treatments. And so in this particular question, we have Elidil that was indicated. That's one of the first line treatments. It is a cream, very safe. You rub it on the frontal hairline. The anti-androgens, finasteride and dutasteride, are among the most effective treatments for frontal fibrosing alopecia. And so I consider them first line, especially dutasteride. The vitamin A, isotretinoin, and acitretin are also first-line agents, in my opinion, because they can be very effective in helping frontal fibrosing alopecia. Now, there are side effects of these medications. They can't be used in women of childbearing age. Dutasteride can very rarely affect weight and weight gain very rarely affect mood, but that's not common. Isotretinoin can affect cholesterol. It can cause dry lips, dry eyes. You can't wear contact lenses. So it's not to say these treatments aren't without some side effects, but these are where I would consider the first-line treatments to stop this particular condition. Then we have the antihistamines and hydroxychloroquine in second-line agents, and hydroxychloroquine goes by Plaquenil. Many of you are familiar. Doxycycline is right there. Topical steroids are right there. Minoxidil is right there. And so often we use some first-line agents and maybe 1 or 2 second-line agents. And if a patient is not getting better, then we might say, do I want to use, is there any other first-line agent I can use, or the patient is okay with starting? And if not, then we'll look at our second-line agent list. And if a patient says, I don't want any of those, then we look at the third-line agents. And so we start logically with first-line treatments, then we move to second-line, and we move to third-line. These are my treatments for frontal fibrosing alopecia, and I have these boxes of first, second, and third line for every hair loss condition. Your physician might have a slightly different order, but most hair loss dermatologists around the world would be somewhat similar. There may be subtle differences, of course, but somewhat similar. And this changes over time as we learn more. And so this list next year, in the summer of 2023, might look a little different. There might be a new treatment, new evidence. One of these treatments might come down into the second-line agent. Something down here might move up into the first-line agents. And so that's the order that I consider. And so when I see a patient with frontal fibrosing alopecia, especially a postmenopausal woman, which is one of the most common presentations, I'll often think about starting finasteride or dutasteride if there's no contraindications or reasons not to. And we might start a non-steroid cream like Elidil. I might do steroid injections across the front. I might send the patient home with an antihistamine. I might have them use a hypoallergenic shampoo. And I'll see them back in 3, 4, 6 months, and we'll see how we're doing. And then we'll decide if we want to add another agent. And so in your particular story, for question number 3, I don't know the full story, so I don't know if there's a reason why we can't use some of these medications, but that is the list. So question number 4, the patient says, I'm currently on hydroxychloroquine, Plaquenil, ketoconazole shampoo, doxycycline, biotin, vitamin D. And so as I'm reading this, I know that this is a patient with a scarring alopecia. I'm on clobetasol, which is a steroid lotion, fluocinolone oil, which is another oil. I'm using the iRestore helmet, which is a low-level laser device. Since I've lost a lot of hair and I still have a lot of active inflammation, my doctor advised me to stop doxycycline and start prednisone, an oral steroid, and mycophenolate mofetil, an immunosuppressant medication. Do these combinations of medications sound usual, normal to you? Is this what is used for these types of scarring alopecias? The patient wants to know. Mycophenolate mofetil has many side effects, including skin cancer. How safe is it? Is it okay to continue with laser along with prednisone and mycophenolate mofetil? So this is a patient that has a scarring alopecia, a type of hair loss condition where the body is trying to form scars in the scalp. And so here's my list for lichen planopilaris, my first line, second line, and third line boxes. And so in this question, the patient is on a topical steroid, clobetasol and fluocinolone oil. They're on doxycycline, hydroxychloroquine. So they're on 3 first-line agents. So absolutely, these are normal and usual treatments. The patient has been suggested mycophenolate mofetil, which is an immunosuppressant to weaken the immune system to try to stop this autoimmune disease. They're considering prednisone, and they're on a low-level laser device to try to stop inflammation as well. And so, do these combinations seem normal? Absolutely. These are within very typical strategies we use for lichen planopilaris, and frontal fibrosing alopecia is similar in some ways, but these are very typical scarring alopecia protocols. Mycophenolate mofetil has many side effects, including skin cancers. How safe is it? You're absolutely right. This is an immunosuppressant medication, and so we do worry about small increased risks of infection, small increased risk of cancer, small increased risks of viral infections, for example, like shingles, blood count changes. And so there's a nice study from February of this year which looked at how safe is mycophenolate mofetil in lichen planopilaris. And this is an oral immunosuppressant medication which is used for lots of autoimmune conditions. It goes by the names Cellcept and Myfortic as the trade names. And it was approved in 1995 for kidney transplant patients, heart transplant patients, and liver transplant patients. And so we can borrow it in the hair loss clinic as what we call an off-label treatment. So it's not approved for lichen planopilaris. There's no treatment that's approved for lichen planopilaris formally by the FDA, but you can see that we have these 25 treatments that we can use off-label. And so this particular study from February looked at 6 studies that were published in the past, and there were 94 patients in the medical literature, in the journals. Some had 5 patients in the study, some had 66 patients. And here's the side effects of mycophenolate. And we sometimes use mycophenolate mofetil for lichen planopilaris. 5% had increased liver enzymes, urinary tract infections, swelling in the feet in 2%, increased sensitivity to the sun in 1.5%, lower red blood cells, which we call anemia, increased cholesterol, 0.7%, and shingles or herpes zoster in 0.7%. And so from the perspective of an immunosuppressant, it has very typical immunosuppressant concerns, and that's infection. We saw that shingles is increased very slightly. Less than 1 in 100 people get shingles in this study. But we worry about skin cancer, maybe a small increased risk. We don't know for sure in lichen planopilaris patients if it's increased, but certainly in organ transplant patients there may be an increased risk. But it's not clear. Some studies recently are suggesting that maybe mycophenolate mofetil doesn't have quite as great of a cancer risk as some of the other immunosuppressants like cyclosporin and azathioprine. But we certainly wonder about it. And so there are some studies which suggest yes, some studies suggest no, but it seems that it's a very, very low risk. And again, this is generally after many, many years of chronic use. It can change blood counts. Mycophenolate can't be used during pregnancy. And so, thank you for that question. It's a very common treatment plan that you've been prescribed, and mycophenolate tends to be fairly well tolerated. Patient says, I've had alopecia universalis, total loss of scalp hair from this autoimmune disease, alopecia areata, for 6 years. It started with alopecia areata at 23 years of age. My patches always grew back, and that's very typical of alopecia. It falls out, comes back, falls out, comes back, until 6 years ago, when everything fell out in a matter of months. Although I have alopecia universalis, I've had all the health checks I could possibly have. They've all come out good. I know my body is good. I have a slightly underactive thyroid, which is common in alopecia areata. The hair loss is a mystery. And so alopecia areata is often a mystery. The causes of alopecia areata are strongly genetic. From the day you were born, there are genes that we know that are in the body, in the hair follicles, in the immune cells, that are increasing the risk for alopecia. And it may be that it takes 2 years before the first patch comes. It may be that it takes 20 years or 40 years or 80 years before the first patch comes. But we know that the genes that are there from the day a person is born are affecting the risk for alopecia areata. So the individual asks, how safe are these JAK inhibitor drugs? You may have heard the exciting news that a JAK inhibitor called baricitinib was approved by the FDA on June 13th, 2022. So about 3 weeks ago. 2 weeks ago. We have numerous autoimmune conditions in my family. Will it trigger something else? Well, we don't think that the JAK inhibitor drugs will necessarily trigger something else, but we do know that when an individual has one autoimmune disease, the chances of another autoimmune disease are increased. And that's for any autoimmune disease of the body. If you have one autoimmune disease, your chance of a second autoimmune kind of disease is increased. And for alopecia areata, we know that there's an increased risk of thyroid autoimmune diseases. And this individual who asks this question has an underactive thyroid. That may be autoimmune-related Hashimoto's. But there's an increased risk of immune conditions like eczema or atopic dermatitis, vitiligo or loss of pigment. These are small risks for vitiligo, but maybe 40% of patients have eczema when they have alopecia areata. And so what are the side effects of the JAK inhibitors? The patient asks, how safe are they? Well, the side effects include infections in about 2% of patients, changes in blood counts. The white cells and the red cells can drop. Sometimes the platelets can go up a little bit. Liver can be irritated, very rarely, but we have to follow those blood tests. There may be a small increased risk of cancer from the JAK inhibitors over many, many years of use. And that still continues to be worked out in terms of what are the risks in different age groups and different populations. May increase the risk of blood clots in some patients, increased cholesterol levels, increased creatinine, which is a measure of kidney function. 6% of patients get acne, and there may be an increased risk of heart disease, at least in studies that have been done in older patients with rheumatoid arthritis. And some of the JAK inhibitors, like tofacitinib, might increase the risk of colon perforation, especially if you have diverticulitis. Now, that's a small risk, and it may not be the case for other JAK inhibitors. How regularly do you need monitor when you take these drugs? Well, we need blood tests every month for 3 times. Month 1, month 2, month 3. And then after that, we need blood tests every 6 to 12 months. Every 12 months for sure. We need skin checks every year to check for skin cancers. We need blood pressure checks every now and then. When you stop taking it, does the hair just fall out? And that's correct. In most patients with more advanced forms of alopecia, the hair does fall out. And so it is a drug to be taken for life. There are some patients with some more mild alopecia where we can get the hair to grow back. We can taper off these medications and hope that the hair stays. And sometimes it does. And if there's an episode in the future of hair loss, we can resume treatment again. Will there be more drugs for hair loss coming out soon? Absolutely. June 13th, 2022 was a really important time in history of alopecia areata. But we will see the next FDA approval in the near future, and there'll be drugs after that, and there'll be more in 2025, 27, 30. The door is open now. It's a very exciting time in the hair loss world. And, before June 13th, I could say that there was only 2 drugs that are approved for hair loss. That is minoxidil for androgenetic hair loss or male balding and female thinning, and finasteride for male balding. There's no FDA-approved treatment for alopecia areata before June 13th, no FDA-approved treatment for scarring alopecia, no FDA-approved treatment for trichotillomania, no FDA-approved treatment for, these other issues. And so June 13th was a really exciting time. Who do you advise not to take this drug, the patient asks. So patients that are not willing to accept the risk, that's the number one. So with your physician, we really need to go over these side effects and understand what is the magnitude of this risk. Is it a small risk? Is it a big risk? If the chance of a particular side effect is 1 in a million, there are some patients that will say, 1 in a million, that's nothing. I want to take it. There are other patients of mine that will say, 1 in a million? Are you kidding? That's so high. I don't want to take it. So we have to review the risks, but we also have to review the magnitude of the risks and the patient's own risk profile. I don't use it in patients with cancer, patients with significant risks for heart disease. We can't use these medications during pregnancy at the present time, although that's being studied. Patients with high liver enzymes or low blood counts, patients with immunosuppression to begin with, HIV, AIDS, patients with cancer, we don't use these medications. So thanks for that great question. Please explain shedding associated with oral minoxidil. How much shedding occurs and for how long? Will the shedding stop if you stop the oral medications? Or once the shedding starts, does it need to just run its course? So thanks for this question. Oral minoxidil is the tablet form of minoxidil, which is used topically. One of the popular trade names is Rogaine, but there's a tablet of minoxidil which is very popular. There are side effects of it. Increased hair on the face, swelling in the feet, palpitations of the heart, chest pain, and hair shedding. And Dr. Sanabria from Brazil had a really nice study last year showing that maybe 44% of women have hair shedding when they start minoxidil, and 22% or something of that matter of men have shedding. So shedding issues are really common with starting oral minoxidil. It generally occurs for anywhere between 6 weeks and 3 months, somewhere in there, and it usually stops after that. Not in everybody, but it usually stops after that. If you stop the oral minoxidil, does the shedding stop if you just can't take it? Usually it does, but it can take anywhere from 1 week to 1 year. And not everyone stops, but most people do. And in some people, it's very quick. You just can't take the shedding anymore. You don't want to wait 3 months. You just don't like this. Some people it stops very quickly, but generally it takes a few months. But in most people, the shedding happens for 6, 8, 12 weeks, and then it stops, and the hair grows, and there's an improvement in androgenetic hair loss. Can one experience simultaneous shedding and growth at the same time? Or once shedding starts, does that mean all the growth has paused? Absolutely, you can have shedding and growth, and in fact, usually you do. And so usually when you look at the scalp of someone who says, I'm shedding, I'm shedding, I'm shedding, look at the bags of hair I'm bringing into you. When you look at the scalp, you see all these pointy hairs all over the scalp. That's new growth. And so usually you see shedding and growth happening at the same time. Same patient says, I've been on Xeljanz, which is a JAK inhibitor, for 10 months and had full regrowth without any shedding or any patches. Then I got COVID followed by the flu, which set off a cascade of shedding and now patches. I've also stopped Xeljanz for a week to fight the COVID infection. Have you seen this in patients that have experienced a similar pattern? Did the shedding and patches finally quiet down, or did they end up losing their full head of hair again? Do patients need to switch meds ultimately? Does Xeljanz ever stop working? So thanks so much. Absolutely, this phenomenon has been seen many times during the pandemic. Infection can sometimes activate alopecia areata. A large proportion of patients regain hair back. It can take a little bit of time, but a very high proportion of patients regain hair back. In some patients, taken on a case-by-case basis, we may discuss whether we want to do some local steroid injections in areas that need help, or to use topical steroids, or to use topical minoxidil to help the Xeljanz or tofacitinib work better. But it's by no means an indication that this is just going to get worse and worse and worse and full baldness is going to happen. Not at all. The most important word with alopecia areata is the word uncertainty. And so these are generalizations. The expectation is for it to improve slowly over time. But there are some patients that have courses whereby they lose more hair, and it just seems like the Xeljanz doesn't work quite as well anymore, or the tofacitinib. And so even without COVID-19, there are a small proportion of patients that do really well on JAK inhibitors, and then after a while, a patch starts and a patch starts again, and it just seems like it's losing its effect. That hasn't been really well studied, but it's certainly something that we watch for. So it's not impossible, but fortunately, many patients do really, really well. And so there's a little bit of uncertainty here in this particular question, but about what will happen. But for the vast majority of patients, the news is good, and that is once the Xeljanz is restarted after the infection stops, and sometimes supplementing with a little bit of help from steroid injections or topical steroids, the hair regrows. Question number 7. Is there any link between lichen planopilaris, which is a scarring alopecia, and autoimmune thyroid disease? And the answer is yes. And that is that a study from 2014 showed that 34% of patients with lichen planopilaris have thyroid disease, compared to 11% in the population generally. And so it's about a 3-fold increased risk of thyroid disease. Can you use PRP if you suffer from autoimmune thyroid disease? It's a great question. And, for the first many years of doing PRP, we sort of said, if you have any autoimmune disease, you shouldn't have PRP because we just don't know what it will activate. And there's some truth to that. We have to be a little more cautious with doing PRP with autoimmune disease. The reality is that autoimmune thyroid disease is very common in human beings. And so there's not a lot of really great evidence that we really need to change what we do in patients with thyroid disease. So if a patient comes in with stable thyroid disease, they're on thyroid supplementation, their TSH has been normal, it's been stable, there's not a real good indication that we can't do PRP. But again, this is to be taken on a case-by-case basis, and each patient needs to discuss it with his or her physician. If during the last 2 years the hair loss didn't suffer any change, is there a chance that I can see regrowth? In the last 6 months, I did several injections with cortisone. So again, this patient has scarring alopecia, and things have been pretty stable for 2 years, and the patient's saying, can I get regrowth? There's always a possibility to get regrowth in scarring alopecia, so it's not always permanent. Not everyone does get regrowth, though. But the first thing is we need to absolutely make sure that the scarring alopecia is quiet, that it's been put to sleep, that it's dormant. And if it's not, then we need to increase the treatments that we use to quiet the scarring alopecia. And then if the scarring alopecia truly seems pretty quiet, then we may want to try to cheer hairs along that are trying to grow and struggling to grow with things like oral minoxidil, topical minoxidil, low-level laser, or PRP. But step 1 is to make sure the scarring alopecia is quiet. We need to put out the fire, and that's step number 1. How do I make my hair stronger? At this moment, my hair is very dry, very thin. What supplements can help? So I'm not a huge fan of reaching for supplements at this point to address this particular question. The first thing is we want to make sure the disease is 100% stopped. Not 90% stopped or 92 or 94 or 96, 100% stopped. If the disease is still grumbling along, then the hair is going to be thin, it's going to be dry, it's going to break. So we need to stop the disease. We want to make sure that there's no other conditions that are present. We want to make sure that there's no iron deficiency that's contributing to hair breakage. We want to make sure that the vitamin D levels are sufficient. We want to make sure that there's no seborrheic dermatitis on the scalp or dandruff. Seborrheic dermatitis is extremely common in scarring alopecia, and this can contribute to hair feeling dry and thin, sometimes oily, but sometimes dry. Whenever a patient says, my hair's so dry, we want to really look at the cosmetic aspects of shampooing. Some shampoos are drying. So some shampoos like ketoconazole can be extremely drying. So how is it being used? There's occasional patients that come in and say, I leave the ketoconazole on my scalp 15 minutes. That's far too long. The directions say 3 to 5, and sometimes all that's needed is 1 or 2 or 30 seconds. So we need to look at the shampoos. Sometimes we need to change the shampoo. If the patient needs an anti-dandruff shampoo for their seborrheic dermatitis, perhaps we use a zinc pyrithione shampoo. Perhaps we bring on board a hydrating treatment like fluocinamide oil or another type of oil that can be helpful. Supplements are probably my last go-to, except if there's a true deficiency like low iron or vitamin D, then let's have a vitamin D supplement or an iron supplement. And then we want to cheer the hairs to grow, laser, PRP, oral minoxidil. Question number 8. How do you know if you have both androgenetic hair loss and scarring alopecia, specifically lichen planopilaris? So the answer to that, before I read more, is an examination. So generally speaking, with a proper examination of the scalp, we can determine if a patient has scarring alopecia and androgenetic hair loss, or scarring alopecia or androgenetic hair loss. So these examinations are wonderful, and they're a trained physician can generally diagnose these two conditions. If there's any doubt, a biopsy can clarify it. And biopsies are really wonderful if they're done properly from the right area of the scalp. So androgenetic hair loss is most active here. And so you don't want to be taking a biopsy here. I'd like to take it back here because I don't want my patient to see the scar. So we're going to hide it back here. That's not the right approach. Androgenetic alopecia is here. Lichen planopilaris is most active here in the front. That's where we want to take the biopsy. We don't want to be taking it from the back. If you send your biopsy to a pathologist who enjoys reading pathology, that looks at this hair slide, case number 457B, rule out scarring alopecia or androgenetic hair loss. Oh, good, I can't wait to look at this slide. That's who you want to send the slide to. A pathologist who looks at the slide and says, oh, I don't really like reading hair loss. That's not who you want to send the biopsy to. So we want a biopsy from the right site. We want it taken with a 4 millimeter punch. So it has to be the right size. Ideally with horizontal sections. That's the way the lab is going to process it. And ideally with a pathologist who enjoys reading the pathology. And then once the biopsy comes back, the doctor or the clinician has to pull out the chart and say, here's the biopsy report in my right hand, and here's the chart in my left hand. Does this make sense? Does the report line up with the clinical information? And so the answer to this question that question 8 is a biopsy could really help if the diagnosis can't be rendered clinically. So the patient says, I was diagnosed with LPP and I have a very obvious patchy hair loss on my crown. However, I'm noticing diffuse hair loss at the back of my scalp as well, not in a patchy pattern per se, but sparser hair in a wider part when I pull my hair to the side. So when the hair is parted in the middle, it's a wider part. How does one get tested? So a clinical exam with trichoscopy should give the answer with a magnifying device, but if not, a biopsy will be very, very helpful. Question 9. Question 9 of 11. I think there's 11 that have been submitted. What role does the gut microbiome play in known and suspected autoimmune diseases like lichen planopilaris and associated conditions like rosacea and Hashimoto's? The gut microbiome plays a really important role. We do not have all the answers yet, and that's really the most important point, but the gut microbiome plays a really important role. And we don't have a lot of great recommendations in the year 2022, and it's tempting to say, take a probiotic. But the reality is we don't have a lot of great evidence for that, but we do have a lot of evidence that the microbiome is different in patients with different types of hair loss. And there's no doubt about it that this is contributing in some way. But we don't really know how to manipulate that yet. It certainly seems pretty reasonable that diets rich in fruits and vegetables may facilitate a very good microbiome. We don't have the evidence yet that that translates into inactivity of scarring alopecia or improvement of alopecia areata or improvement of androgenetic hair loss. But there's a hint. There is a hint of it, of these associations. And so we need better studies and to figure out what this all means. Should we all be eating, fermented foods? Maybe. Should we be eating, foods that protect our microbiome? Maybe. I think in general, foods that help create a microbiome that's good are generally good for us. They reduce the risk of many, many conditions, metabolic conditions, perhaps cancer, perhaps cardiovascular risks as well, and perhaps some of these hair issues as well. So stay tuned. It's a new field, but it's probably way more important than we realize. Question 10 says, I had a biopsy, 0.3 centimeters, with regular trichoscopy or magnification. Based on what the doctors claim, it's lichen planopilaris. And others say it's not that at all. Everyone agrees it's seborrhea. This is a very common scenario in my everyday. A patient has a biopsy. Some doctors say it's lichen planopilaris. Some doctors say it's not lichen planopilaris, it's seborrhea. So the individual says, here's what the biopsy says. Histologically, on the surface, there's an ortho and focal parakeratotic acanthotic epidermis with a keratin plug in a dilated follicular orifice. And that's how these biopsies read. And so it does take a little bit of interpretation. In the dermis, or the lower part of the skin, there's a scarce mononuclear inflammatory cells. These are the white blood cells that are seen around the blood vessels perivascularly, showing some signs of mild exocytosis into the epidermis. So these white blood cells are booting up into the upper layers of the skin. Hair follicles are reduced. So when I read this, because I certainly read a lot of biopsies, there is no evidence for the pathologist telling us there's lichen planopilaris in this report. Now, the patient may have lichen planopilaris, but this report is not a report of lichen planopilaris. But let's come back to that in a minute. The individual has given us a little more information. Here's a little more background. Hair has been falling out periodically for 2 or 3 years, mostly temporally and occipitally, so in the temples and in the occiput. But it would start falling out a few months after the corona and the flu. There's been low iron and there's been ferritin and low vitamin D that I take supplements for. Other blood counts are normal, gynecologic exams are normal, dental findings are normal, without constant therapy all the time. So the patient's not using any constant therapy. Therapies come and go. So what do we make of this? So the first thing to mention, and the question from the individual here is, do you have any ideas what this is? So really the most important thing here is that we diagnose hair loss with full stories and full exams. And so every day we get dozens upon dozens of biopsies that come flying in through the emails, and patients ask us, what do you think of it? What do you think I have? What do you think of my biopsy? What do you think? We only diagnose hair loss with a full story and an examination of the scalp. And if I don't know the full story of a patient, and I don't have an opportunity to see the scalp, or at least great pictures, I can't tell a diagnosis. So that's really important. Biopsy reports are not diagnoses. Biopsy reports are clues, and they go right in here. And so we need to knit together the story with the examination findings, with the biopsy and the blood tests, and those 4 pieces of the puzzle come together to give the diagnosis. So we do not get a diagnosis of hair loss from a biopsy report alone. That's really important, and that's where many mistakes are made. So I'd like to walk you through some real simple, for those of you who are interested, some findings of biopsy reports. And for those of you on the webinar tonight that are familiar with biopsies, you might enjoy this quite a bit. But I'd like to review a couple of things about what biopsies show. So in androgenetic hair loss, or male balding, female balding, we see skinny hairs, miniaturized hairs. We see oil glands that are big. They're certainly there, but they're big. And we see inflammation around the hairs. And that comes as a surprise to many people. Lots of inflammation sometimes in androgenetic hair loss. And we see fibrosis or scar tissue around the hairs as well sometimes. And that comes as a surprise too, because many times we think that's scarring alopecia, but it's not. So what do we see in hair shedding problems like telogen effluvium? Well, you look at the biopsy and you see a lot of terminal hairs. So you see lots of hairs sitting down there in the skin. There's less of them because some of them have shed. You see normal oil glands. The oil glands are there. Not really that much inflammation and not usually that much fibrosis. What about alopecia areata, this autoimmune disease alopecia areata? Well, sometimes we see miniaturized hairs, sometimes very small hairs. But miniaturized hairs are really common. We see the oil glands are present. There's inflammation, but it's deep down, deep in the skin around the bulb. Just like a flower has a bulb, hairs have bulbs, and they sit deep in the skin, and that's where the inflammation is in alopecia areata. Not much fibrosis. And often in alopecia areata, you see a lot of shedding hairs in the biopsy, a lot of catagen and telogen hairs. And what about in lichen planopilaris, FFA, CCCA? Well, you often see injured hairs. So you see hairs whereby the outer part of the hair follicle has been hurt or damaged or even killed, and we call that necrosis or apoptosis. And sometimes in a biopsy report, you'll see the term lichenoid inflammation. But we often see loss of the oil glands. And so when I get a biopsy back from a patient who is suspected of having scarring alopecia, the first thing I look for is, what did the pathologist say about the oil glands? And if the pathologist says the oil glands are really big, there's so many of them in this biopsy, my feeling is, wow, that's strange. Usually the oil glands are reduced in scarring alopecia. Now, not always. Early stage, there can be different findings, but usually there's loss of the sebaceous glands. There can be inflammation around the hairs and scarring around the hairs, just like in androgenetic hair loss. And so if the pathologist says, I see inflammation around the hairs and I see scarring around the hairs, I don't get too excited about that because that's not really a very specific feature. Now, if there's really dense scarring, then that certainly can be important. If there's a type of scarring where there's a certain type of material called mucin deposited within the scarring, that's called mucinous fibroplasia, then sometimes I get a little worried that it's a scarring alopecia. But the key thing here is loss of the oil glands and injured cells. The things that aren't usually too helpful in a biopsy report is what's happening in the epidermis, the upper layer. And so in this particular biopsy report, the pathologist speaks about the scaling on the surface and the plugging of the pores. That can be relevant sometimes, but it's usually not the key finding. And inflammation around blood vessels usually isn't super helpful for us. And inflammation around the hairs and scarring is not always super helpful because it can be seen in androgenetic hair loss. And so when we come back to this biopsy, the pathologist says on the surface, there's all this blah, 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 blah. So that's not helpful for me really because this is what's happening on the surface. I need to know what's happening in the skin, deeper down. The biopsy says in the dermis, there's inflammatory cells around the blood vessels, and some of the inflammatory cells are creeping up into the skin. So that's not really helpful for me as well. Inflammation around blood vessels, not usually too helpful. What I'm really craving to know in this biopsy report is what's happening to the oil glands. Is there any miniaturizing hairs or vellus hairs? Is there an increased number of shedding hairs or telogen hairs or catagen hairs? And is there any death of hair follicle cells, necrosis or apoptosis or what we call lichenoid inflammation? And so we don't have any of that in the biopsy. This particular biopsy report is a story of seborrheic dermatitis. And so the only thing I can read in this biopsy is that this patient's probably had a biopsy from a site of seborrheic dermatitis. Now, the pathologist does say that there's a decreased number of hair follicles, so it seems that the patient has hair loss. But I don't know what type of hair loss it is from this biopsy report. The story of the patient is certainly not particularly suggestive of a scarring alopecia. The patient has not been on any type of therapy, and the patient is telling us that hair falls out periodically, so it's not constant. That'd be pretty unusual for scarring alopecia to kind of come and go like that. Not impossible, but it's been 2 or 3 years. The patient has some triggers. There are specific areas where it's falling out, so the back and the temple, so it's not diffuse perfectly. So there's nothing really here that makes me think about a scarring alopecia, but I don't really know the type of non-scarring alopecia that is present. So what do we need in this biopsy? Well, in biopsy reports, we really desperately need the pathologist to help us with the sebaceous glands. Are they there or not? Tell us a little bit about inflammation. Is the hair follicle cells dying or not? That's really helpful. And what's happening to the hairs? Are they all big hairs? Are some of them thin hairs? Are all the hairs growing hairs, or are some of them shedding catagen and telogen hairs? So those are the features of good biopsy reports. And so when I have a biopsy report that comes my way, I can immediately tell within seconds if it's a biopsy report from someone who enjoys reading biopsies or someone who doesn't read biopsies as frequently. Now, that's why these are so important. But the other thing that's so important for any clinicians on the webinar is when you submit your biopsy report to the pathologist, it's really important to say to the pathologist, "Dear pathologist, I have a patient who's 32 years old, who has an itchy scalp. When I look at the scalp, I'm seeing maybe features of androgenetic hair loss. I'm not sure. I don't think it's scarring alopecia." That goes a long way, instead of sending the biopsy report to the pathologist saying, "Dear pathologist, please tell me what you see." And sometimes that's done. On the report, it says, "Dear pathologist, hair loss, tell me what you see." And that's not helpful. So we need that two-way discussion between clinician and pathologist. So finally, question 11 is our final question, then I'll take any questions in the chat. Patient in the early 40s with premature ovarian failure, which is a condition where the ovaries undergo early menopause instead of at age 50 or 55. I think the average in North America is 51.4. It's an early menopause. That's premature ovarian failure. And so there's less estrogen around because the ovary is making less estrogen, and sometimes less androgens as well. Patients started taking a hormonal treatment with estrogen and progestin, as well as an estradiol patch for a long time. Started taking an estrogen and a progestin, as well as an estradiol patch. The patient's a long-time user of spironolactone, which is an anti-androgen. In 2020, prometrium was added, mostly to help with sleep. Premature ovarian failure can be associated with the findings of menopause, poor sleep, hot flashes, as well as other issues as well. In early 2021, added DHEAA, stopped because there was worried it was causing hair loss, and in 2021 had some thinning. In 2021, significant thinning was visible at the temples and the hairline. In January 2022, minoxidil was added. Patient says, "I've read a lot of conflicting information about Activella, and the progestin in Activella is androgenic. It's norethindrone acetate. So one of the chemicals in the hormone pill, the estrogen and the progestin, may be androgenic sometimes. It can be interpreted by the body as being almost like a male hormone." And the patient wondered if it was worsening the hair loss, so stopped in February, and things have gotten worse. The patients continued with spiro, estrogen, and prometrium. So the question is, did stopping the Activella make it worse, and would it help to go back on Activella? So this is a really complex question. And so I think that's the most important thing here. And I think that there are key features of the history that I would need to really answer fully. It is a really complex question, but I hope that the answer here will be helpful because there are some important principles. I think the most important thing here is that for patients of my own with similar issues, and I see many women with early menopause, premature ovarian failure, premature menopause, that we need to have the discussions with the gynecologist. And so in this particular question, it could be that the progestin in the Activella is androgenic and is interpreted by the body as being a male hormone, and that's causing hair loss. But what I'm slightly more concerned about here would be actually that the reduction in estrogen from stopping the Activella, that beta-estradiol has actually triggered a hair shedding phenomenon because there's less estrogen around. Both are possible, but I would slightly more favor that the actual reduction in overall estrogen may be contributing to a bit of a shedding. Could there be some telogen effluvium or shedding from starting the minoxidil in January? That is very possible here. And some people get a very robust shed from minoxidil. Sometimes it's scary with minoxidil. Fortunately not for most people, but it can be. So is minoxidil actually causing a shed? And is the combination of stopping the Activella and starting Rogaine just perpetuating each other and causing a shed? And so it's hard to know, but trying to go as slow as possible, and that's hard when anyone's losing hair, can be valuable to sort of sort things out. But there could be other issues. The world saw massive Omicron infections in December, January of 2022. And, 40 to 60% of the population in some areas was infected with Omicron, and this can cause shedding, even if it's asymptomatic. So was there an asymptomatic COVID infection mixed into this puzzle? That would be important to get that history. And sometimes when you speak to patients say, oh yeah, actually I forgot to mention I was sick. I had 2 weeks off work. I had Omicron in January. So this is a complex situation. I really appreciate this question. It's very valuable to address. In some patients, the reduction in estrogen is really a trigger of hair loss, in my opinion. And it could be that speaking to the gynecologist about going back on the Activella is one option, but adjusting the dose of the estrogen patch, depending on what type of patch is being used, there can be higher doses that are used. And maybe in combination with the gynecologist, a decision might be made that another type of estrogen is just more reliable or easier to use, or if there's any issue with the patch and the reliability of the patch. So these are really important questions, but it could be the sudden reduction in estrogen as opposed to the increased androgen that's causing hair loss here. So those are options. There's options to keep cheering the hair on. Even though it's shedding, keep cheering it on. Keep going with the topical minoxidil, start oral minoxidil to cheer, start PRP, start other treatments like topical finasteride. It's a really complex question, so it really does require the dermatologist that you work with to discuss with the gynecologist and have this dialogue because it is so complex. But I'm not so worried about the Activella in this particular situation. It's possible, but I'm more concerned with a sudden reduction in estrogen. So we will keep going to the questions that have been asked. So patient says, I have LPP and I've been recently prescribed Opzelura cream twice daily. Would you recommend continuing with clobetasol every other day as well? Does this cream help with hair loss as well as stimulate hair growth? So it's possible. It hasn't been studied to the same degree, but generally speaking, combining different options, provided someone is monitoring for atrophy or thinning with clobetasol can make a lot of sense. And so continued photography is going to be really important. Am I actually stopping the lichen planopilaris? And if so, then we're winning. And if not, then we do need to bring on board other treatments as well. So photos are going to be really helpful here. What's your opinion on hair loss and prolactinomas? So prolactinomas, for those that don't know, are these tumors in the brain that make prolactin. Most prolactinomas don't secrete enough prolactin to cause hair loss. So high prolactin certainly can. So prolactins in the hundreds absolutely can. Many prolactinomas in the 30s, 40s, 50s, they don't usually cause hair loss. But it depends on what else is affected by the prolactinoma, how big it is, what other hypothalamic or brain issues it's affecting. These macroprolactinomas can tell other structures in the brain to stop making their hormones. And so some prolactinomas do affect hair loss, but most don't. I take bioidentical HRT. If my levels are within normal limits, can it still cause hair loss? It can. Absolutely it can. Even if hormones are in normal levels, it can. Any hormone can trigger hair loss. It doesn't always, so you need to review this with your physicians, but it certainly can. In LPP, does the severity of symptoms like redness, burning, itching correlate with hair loss, or are they separate? So they don't always. Many times they do, but they don't always. And so when a patient comes in to see me with scarring alopecia, my first objective is to get the itching, burning, and pain to 0. Because my hope is that correlates nicely with stopping hair loss. But sometimes itching, burning, and pain is coming from the seborrheic dermatitis that's present in the patient with the scarring alopecia. And there is a phenomenon where it's called a dysesthesia, where we turn off the scarring alopecia disease. We stop the seborrheic dermatitis, but the patient still has pain, still has burning. And that's called a dysesthesia. And so sometimes they are separate. And so that's a challenging situation which really needs to be taken on a case-by-case basis, but usually the symptoms correlate with the hair loss. And so most of the time when a patient says, the first thing they say when they come back for their follow-up, I have no itching, I have no burning, I have no pain, I feel great. Usually that tells me that they're probably going to have an improvement in their hair. I'm 69. I've been losing hair since I was 11. It first started when my father passed away. Many other traumatic things have happened through my life. My hair has progressively gotten extremely thin, and more so since I've been on the osteoporosis medication. I've been wearing a hairpiece for years now. Do you think there would be anything that could get my hair to stop from getting even thinner? I take Nutrafol. My ferritin is rather low. I'm trying to get that up. I'm going to start a new osteoporosis medication. I've been diagnosed with a mild case of Crohn's. I've taken mesalamine for years. Does this cause hair to fall out? Any suggestions? So it really depends on the cause of hair loss. In a patient 69 with hair loss over this period of time, there's quite a high likelihood that there is a component of androgenetic hair loss. But, maybe there are other issues as well, and that really needs to be reviewed. Is there hairstyling issues? Is there chronic traction alopecia? Is there trichotillomania? Is there a scarring alopecia that's undiagnosed? So we really need a diagnosis here. And so I think that's really key here. What could get the hair to stop falling out? I'd encourage you to get a formal diagnosis, and there may be other options that can be considered, like, topical minoxidil if your physicians agree, like low-level laser. But it just depends on the diagnosis. Thank you for that question. I've been diagnosed with LPP, and my doctors prescribed me topical steroids, hydroxychloroquine, doxycycline. I tested positive for TB, tuberculosis. My doctor wants to treat me with rifampin for TB. Can rifampin make LPP worse? And will it reduce the efficacy of hydroxychloroquine and doxycycline? And does it require dose adjustment? So it's a really wonderful question. Rifampin certainly can increase the activity of liver enzymes which chew up many drugs. Rifampin probably doesn't make the scarring alopecia worse. There may be some effect on some of these medications. We'd have to look up the 3A4, the liver metabolism of these drugs. And so that would just be something your physician would have to look up. But treating for the latent TB probably makes a lot of sense with this particular immunosuppressive regimen. Does N-acetylcysteine make scarring alopecia? Help scarring alopecia? And are any downsides? N-acetylcysteine might help LPP based on one reasonable study. It's a very small study, 10 patients. Are there any downsides? Well, we don't really know if it helps. So we need better studies. Sometimes it causes GI upset, but it's pretty safe. And there's not a lot of downsides. So it's certainly something to discuss with your physician. But some people do get some mild GI side effects. I'm a vegetarian. Can you suggest foods that are helpful? Anything you should avoid for an LPP patient? I've read that dairy contributes to inflammation. Is that true? Well, we don't know that dairy contributes to inflammation in all patients. There are patients that say, I stopped dairy, I stopped gluten, my hair got a little better. So I'm never opposed to a person avoiding dairy and gluten. But we have to be careful about saying that that is the answer. I think that, the vegetarian diet is probably wonderful for scarring alopecia. You want to make sure you're having a good balanced diet and checking B12, but that is a good type of diet. If I've had Graham-Little syndrome, does this change either the outlook or remission for LPP? So Graham-Little syndrome is a type of LPP, sometimes is a little more challenging to treat, but not always. Treatments are very similar, and so it doesn't change the outlook dramatically in many patients. Have you heard of any association between breast implants and LPP? Not really, but it's continuing to be followed. There's certainly a breast implant illness that is actively being followed. And if you look online at the top 20 studies of 2021 on YouTube and the Donovan Medical Channel, we talked about breast implant illness and a number of hair loss issues that patients with breast implants have reported. It's something I'm following very closely, and there certainly are many patients that report improvements in a range of issues with explantation of breast implants. But it's a challenging issue, and it really needs to be taken on a case-by-case basis. Thank you for your answers. Can you tell me if hair falls out with a white bulb, is that usually a good sign or a bad sign, especially when it comes to LPP? I don't think it's either a good sign or a bad sign. I think that we focus a lot on the bulb. In a massive telogen effluvium, hair falls out with the white bulb. That's not necessarily a good sign. And so I would say that, hair that falls out massively more than normal is not a good sign, whether it has a white bulb, yellow bulb, no bulb. If there are hairs that leave a scar when they fall out, do they have a certain look? Well, initially in some scarring alopecias, it's red and scaly, sometimes pustules, depending on the type of scarring alopecia, but eventually it looks pale, skin-colored, bland appearing with no opening, and that's the end stage of a scarring alopecia. What do you think about low-dose naltrexone for LPP? I think it's in its infancy still. I use it a lot. One nice study from Dr. Shapiro in New York suggested it helps. Another very nice study from Iran, which is a randomized double-blind placebo-controlled study, suggested it didn't help. I think it needs more studies. Certainly low-dose naltrexone helps redness. Certainly low-dose naltrexone helps pain. And certainly low-dose naltrexone helps many people feel that their scarring alopecia is better. And I do think that some of my patients improve on low-dose naltrexone. I do. But what we don't know for sure is, does it impact what's happening after year 2, 3, and 5? A patient can have less redness and less pain, but continue to go on to lose more hair. And so I think this needs to be studied. But I do use it, and I think it's interesting. going to go to the chat. I think that we are close to running out of time. Let me just see if there's anything else. I will take one more question. I've been previously diagnosed with lichen planopilaris after a doctor took a biopsy of my scalp. I had an itchy, flaky scalp, bald patches. After a year of taking hydroxychloroquine, and I had an appointment with another doctor, and he suggested I don't have any bald patches, so he's not convinced I have LPP. So my question is, does LPP always occur in bald patches? And can untreated seborrheic dermatitis cause hair loss? So LPP doesn't always occur in bald patches. There can be a diffuse pattern which looks just like a red scalp. So it doesn't always have to cause bald patches. If left long enough, it usually does. There may be a form of seborrheic folliculitis, seborrheic scarring folliculitis, which does cause hair loss. So seborrheic dermatitis, if it's bad enough, can cause a telogen effluvium. And if it's bad enough, in some cases, if it goes on long enough, it may cause a scarring alopecia. It's controversial, but there's a bit of studies. 18-year-old female with alopecia universalis since March 2020, taking tofacitinib, started at a lower dose with no change. I increased to a full dose and had full regrowth. March 2022, I started shedding and it's at 50% left and I'm still shedding, losing eyelashes. My question is, should she continue with tofacitinib or change to another JAK inhibitor, baricitinib? And how long should she wait to decide? Don't know what started the shedding. Perhaps COVID? I don't know. And so 3 months of shedding on tofacitinib, losing hair very quickly. Certainly in a situation like this, we want to make sure the thyroid is okay, iron is okay, all of those things are okay. This is a challenging situation, especially at 20 milligrams where, we're at pretty high doses. I might be apt to, on a case-by-case basis, start a topical steroid with it, topical clobetasol. We have to be cautious about using, prednisone with tofacitinib, two strong immunosuppressants, but perhaps topical steroids or steroid injections, and maybe bringing on board oral minoxidil in some cases, depending on the patient. But a pretty low threshold if the amount of hair loss stops dropping more below 50% by August, September, I probably would make a change, especially when we're on 20 milligrams already. And I think everyone that submitted the questions, we'll have many more of these webinars as we go along. We do have a question of the week, which is very popular, and I wish I could answer everyone's question, but please do consider submitting questions to the question of the week if you are okay with me answering the question in a public forum. It helps many people, and I enjoy being able to help in that manner, and the question of the week is on the website. But I will sign off now. I thank you very much. I wish you a wonderful summer, and I'll look forward to seeing you again on our next webinars. Thanks, everybody.